Good afternoon, good evening. Thank you for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent. And today we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based in DRC. I will now hand over the floor to Dr. Ngashi to start the session. Over to you, Dr. Ngashi.
Yes, thank you very much, Director. Good morning, good afternoon, colleagues, depending on where you are right now. We are very pleased to have you again join us for this week's press briefing on the situation on Mpox on the continent. We are at a very interesting moment. On one side, we hear about the health financing crisis that is going on. But at the same time, we also have the outbreaks that continue on the continent, not only Mpox, but also other outbreaks. Meaning that we are called to deliver on the result, but at the same time with much greater efficiencies to manage more than one outbreak with limited resources. Today is just an opportunity to take you through where we stand right now, more particularly on Mpox and cholera. That's what we are going to brief you about today. Now, with that, Director, if we can then go through the PowerPoint presentation. Now, let me start first with some of the partnership activities that have happened during the course of last week and this week. Now, I'll start with the visit of His Excellency, the Ambassador Al Kumar Rai of India, who visited Africa CDC at its headquarters in Addis Ababa. You know, it is an opportunity to discuss opportunities for collaboration between India and Africa CDC, looking at areas like manufacturing of pharmaceutical products that we all know that India has got many years of experience as Africa CDC also embarks on the same agenda that we call the second independence of Africa. I think we have a lot to learn from the Indian experience. Next. Next slide, please. Yes, I think as we reported last week, on June 4th, we had a meeting of head of state on cholera that ended up with a call to action. Just 2 days after that meeting, the Director General visited Angola. It was a time for him to meet with the head of state and also assess the situation on the ground. As you know, Angola is facing the outbreaks of cholera and Mpox at the same time. It was also an opportunity for the Director General for bring some of the support from Africa CDC, including the IPC and oral rehydration supply to support the ongoing outbreaks. Next. Now, coming to the public health event, just to say that we are tracking how many events that have been recorded, we have recorded since the beginning of the year and compare with the situation in 2024. Now we can say that there are 131 events that have been reported from week 1 up to week 24. As we can imagine, we still have about 28 weeks to go, but the number we have has already exceeded half the number of events that were recorded in 2024. And when we look at then the high-risk events, there were 32 recorded compared to 72 last week. That means we have already half of what is recorded during the entire year of 2024. On the moderate risk event, we have exceeded already half of the 147 events recorded last year, and that is 95 that have been reported so far. And we have the 5 top diseases which remain the same. Is cholera that comes number 1, affecting 21 member states, but we have reached almost 150,000 cases. and 200, almost 3,000 deaths that have been reported. Then it is followed by Mpox, also affecting 21 member states, 67,000 cases, 20,000 confirmed cases, 519 deaths. And also we have measles, dengue, and Lassa fever that also join the top 5 diseases that are affecting the continent as far as public health events are concerned. Next. Now, on the Mpox situation, I think we can see, first of all, that do we have a cumulative number since the beginning of 2024 up to 25 of 145,000 cases and almost 40,000 confirmed cases, 1,796 suspected deaths, and 196 deaths among the confirmed cases, giving us case fatality rate of 1.2% on suspected and 0.5% on confirmed. I think 25 member states have been affected out of the 55 member states that we have in the African Union. But when you look at the epi curve, we can see some trends toward a downward slope over the last 3 weeks. And when we look at the number of cases reported during week 22, on the notified cases, we still notice a slight increase of about 4.2%. On the confirmed cases, that's where we see now a 30% decline from 1,027 confirmed cases in week 21 to 717 in week 22. Similar trend on dates as well, where we had 5 dates reported in week 21 and 3 dates reported in week 22. But what is very important to say is when we compare the number of cases in 2024 and the first 22 weeks of 2025, it's quite striking to see that already we have reached 80% of all the cases reported in 2024 on the suspected cases, and we've slightly surpassed, the 100% of cases that were reported now here, confirmed cases in 2024. Just to say that from this trend, it is clear that this year will end up with double or more than double the number of suspected cases and confirmed cases that were reported in 2024. Also important to say that Sierra Leone, which is the last, one of the last countries to show that exponential growth in the number of cases, accounted for 63% of new confirmed cases during week 22. Next. Now, when we look at the epi curves of the 3 countries that account for 86% of all confirmed cases during week 22, which include DRC on the left, Sierra Leone in the middle, and then Uganda on the right, I think what we see is that across the board, we see a downward trend, in all the 3 countries. But as we say, I think we still need also to interpret this with caution, given the many challenges that we are still facing on the surveillance side, especially that in most of these countries, surveillance has remained predominantly passive. Next. Now, trying to zero into specific countries, we start with Sierra Leone. I think what we see is some positive development with the downward trend observed over the last 3 weeks. And also in exchange with our colleagues in Sierra Leone, it seems that that downward trend is also maintained in week 23, I think, which is something very encouraging. But in total so far, 4,482 suspected cases, of which 3,523 confirmed and 17 deaths. That gives us a case fatality rate of about 0.5%. all the 16 districts of Sierra Leone are affected. And when we look at the performance in week 22 in comparison of week 21, it is clear that we have a decline on the notified cases as well as on the confirmed cases, respectively 15 and 22%. But on the confirmed cases, I think we are still dealing with clade 2B. Males make 51% of all the cases, and children just about 3.9%, which means it's an outbreak which is predominantly in the adult population. On the testing side, testing coverage remains at 100%, meaning that all the suspected cases are being tested. The testing rate is also 100%, meaning that all the samples that are brought in the laboratory are tested. But our concern remains the one of the test positivity rate, which remains high, although we see a slight decline from 93% last week to 85%. But it still shows that people come late and they come on their own to the health facilities, that the surveillance still remains a passive surveillance. Now, on the results turnaround time, Sierra Leone stands at 2.5 days, which is quite good and encouraging. There are 958 active cases of Mpox that are being followed up. But when you look at the number of active contacts, it's about 1,690. I think that's where the greatest challenge of Sierra Leone is on the surveillance, is those 2 points. One is that surveillance is passive, and meaning that the people expose already the family and take more time to come into the system to be identified. And secondly, is that the identification of contact is very slow, and it's really suboptimal, also posing serious challenges on the vaccination as well. Because the vaccination, the primary group for vaccination is the contacts, the ring vaccination that we talk about. With only 1,690, it means there aren't many people there to be vaccinated if we also don't include the key population and other vulnerable target populations. Next. In Uganda, we see similar trends, as we said, also going down. A total of 6,581 confirmed cases reported so far, 44 that have died with a case fatality rate around 0.6%. We have 115 districts that are affected out of 146 districts in the country. But during week 22, what we see on the number of confirmed cases, as you can see that we still have problems with the data that comes from Uganda on the number of notified cases. That's an area that we are working with the country to also improve on that side. But when you look at the data on the confirmed cases, I think there's also a declining trend. 113 confirmed cases during week 22 compared with 144 the week before, which reflects a 22% decline. On the profile of the confirmed cases, I think males make 56% and children make 11%, which also confirms once again that the outbreak in Uganda is also predominantly in the adult population, still dealing with clade 1B, which is circulating more in almost all the countries on the eastern part of Africa. On the testing coverage, I think in the absence of the notification, we cannot say, but what we see is on the testing rate, at least the samples reaching the laboratory, all of them are being tested, and the positivity rate stands at 52%, with the turnaround time from collection of the sample to the giving of result, which is now at 72 hours. Now, just to say that Uganda has maintained this continuous decrease over the last 3 weeks. There are still 55 districts that are active right now. One very good news is the fact that Kampala, which was the epicenter of the outbreak at the beginning, did not report any case during week 22. And we really wish that this can be maintained, not only maintained, but also spread to the other hotspot districts as well. Now, Uganda accounted for 16% of all confirmed cases in Africa during week 22. And that's also important to highlight in the case of Uganda that half of the deaths are people that are also living with HIV, meaning that the highest mortality is in the context of co-infection of Mpox with HIV. Next. In the DRC, where we see the high numbers of both suspected and confirmed cases, 109,000 suspected cases, 24,000 confirmed cases, 1,796 deaths among the suspected. That's a case fatality of 1.6%. 115 deaths among confirmed cases. That's a case fatality of 0.5%. 25 provinces that are affected out of the 26 provinces of DRC. Now, during week 22, we had 2,144 cases notified compared to 1,800 the week before. That's a slight increase. But on the confirmed cases, there is a sharp decline of about 42%. That is 123 cases confirmed compared to 301 the week before. But if you just look at the testing rate in the DRC, you notice that the testing rate has declined by almost half. The testing coverage now stands at 13%. That's the reason why we need to interpret that 42% decline on confirmed cases also with caution, given the fact that it might just be the reflection of the declining testing coverage that we see also reflected in the number of confirmed cases. But the test positivity rate stands at 43%, and the turnaround time for results about 48 hours for 84%, almost 85% of all the tests that are analyzed, which is good news, good performance. Now, there are 1,527 cases that are active with 46,940 contacts that have been listed. Just to say that in the DRC, we've really observed a significant improvement on the contact listing and also tracing since the introduction of the integrated database through using the DHIS2. And that 5 provinces in the DRC account for 97% of all cases. I think those are the ones that have been prioritized for the intensification, meaning that's where we are now working with the government to improve the data management of the DHIS2 tracker. That's also where we've really deployed together with the IMS team members, WHO, Africa CDC, and others, the epidemiologists to support the investigation, the sample collection. That's also where we have activated community health workers to be able to strengthen surveillance, risk communication, and also IPC at community level. There's now a targeted and intensified response in those 5 provinces. Next. In Ghana, there also have been a resurgence of cases. If you look at the epi curve over the last 4 weeks, we see there a resurgence of cases after they had remained for quite some time just reporting sporadic cases. Now, they have reached a cumulative number of 772 suspected cases, 50 confirmed cases reported from 10 of the 16 regions of Ghana. That just gives you an idea of the spread of cases. I think they're still managing very small numbers of cases. This is also the right time to really intensify to be able to stop the outbreak at this stage. During week 22, there were 144 notified cases compared to 119 the week before, 13 confirmed cases compared to 12 the week before. When you look at the profile of those that are affected, 60% are males, and children make 31% of all cases. Just to remind that Ghana is still dealing with clade 2B, which is has been also identified in other countries in West Africa. On the testing side, testing coverage stands at 100%. That means all suspected cases are being tested. The testing coverage at 100% as well. I think we don't have data yet on the test positivity. But what we can say that there are about 228 contacts that have been identified so far. But the vast majority of these cases come from three regions, which is the Western North, and the Greater Accra regions. And it's also important to report that really for the very first time, the Eastern, Central, and Northeast regions have also reported cases in Ghana. Next. In Malawi, we can also report that there have already been 184 suspected cases, of which 27 have been confirmed, but no deaths yet, which means that they still have a case fatality rate at 0%. There are 5 districts that have reported cases out of the 28 districts of Malawi, but 85% of all these cases are in Lilongwe, the capital city of Malawi. But data from week 22 show that there were 7 confirmed cases compared to 2 cases the week before. That's a really sharp increase, although still at small numbers. And also looking at the profile of those that are affected among confirmed cases, 74% are males, and children make only about 15%. But Malawi also has clade 1B that is circulating, the same clade that was reported in Zambia and also in Zimbabwe. Now, on the testing side, good performance, 100% coverage rate, 100% testing rate, with a positivity rate around 14% and the result turnaround time of 48%. There are 337 contacts that have been listed, and 80% of them have already completed their follow-up, which is good news, meaning that I think only 20% are still being followed up. Next. In Liberia, since the beginning, 854 suspected cases, 153 confirmed cases. Again, just like Malawi, 0 deaths. That's a case fatality which stands at 0%. But if you look at the epi curve over the last 3 weeks, we see that upward trend, the recent surge in cases that have been reported in Malawi. There were 87 suspect notified cases compared to 67 the week before. There were 41 confirmed cases compared to 30 the week before. That's an increase of 30% and 37% respectively. But when you look at the profile, males make 53% of cases and children make 36% of cases. And Liberia has been dealing with both clade 2A and clade 2B. On the testing side, good testing coverage at 100%, testing rate at 100%, the test positivity rate at 47%. But so far, they do have 63 cases that are still active and 1,458 contacts that have been listed. I think that's a relatively good performance on contact, which gives us a ratio of about 1 confirmed or 10 contacts to 1 confirmed cases. It is still half of the 20 that we are looking for, but it is really a very encouraging progress in the right direction. Can also say that 80% of active cases in Liberia are receiving home-based care, and only 20% that are isolated in health facilities. And also that 41% of the contacts are being actively followed currently. That's 604 out of the 1,458 that I mentioned. Next. Now, on the vaccination side, we can now report that there have been 2.9 million doses of vaccines that have been shipped to the countries of which 2.5 million in the DRC, and the remaining 400,000 to the other 10 countries. That makes in total 11 countries that have received vaccines, of which 7 countries are currently vaccinating. Now, there are more than 664,000 people that have been vaccinated. But when we get the breakdown of the 2.9 million that have been distributed, 1.3 million were distributed through the multilateral collaboration with the IMST, and 1.6 million distributed through bilateral donations, including the 1.5 million that came from Japan to the DRC. We reported last time that Sierra Leone and Zambia were approved for the fourth round allocation, 51,000 doses to both of them, and their upcoming shipment of 97,660 doses from Gavi and UNICEF that are going to Uganda, with the expected delivery date in mid-June, which is just 1 to 2 weeks from now. Next. Now, also some key highlights on the vaccination is that the second plan for the intensification, integration, and legacy, which is Plan 2.0, had estimated the need in vaccines to 6.4 million doses between March and August 2025. But the challenge in terms of supply remains real. We only have 568,000, I think, that are within view, of which 219 that are available already through the US government and just waiting on the emergency use authorization to come from the US. But the quantities of vaccines from UNICEF are still looking for funding. A reason why we really encourage countries and partners that can come to really support the funding, the mobilization of funding for these vaccines are most welcome. As you can see, that the gap is really huge compared to the needs that were estimated at 6.4 million. So what we can also say out of that is that we still have great needs, 3.5 million doses that remain to be mobilized. Sierra Leone received the allocation of 50,000 doses out of the 280 that were requested. You see that the gap is about 230,000 doses that they are still looking for. It is the same thing also with Uganda, that just received half of what they had requested, just to highlight that the needs are really huge. We very much appreciate also the solidarity in this area to help mobilize the needed doses as we move into this phase of the response. Next. Now, that is it about Mpox. We just also prepared 2 slides on cholera to say that the number of cholera cases has continued to increase. There are still the same 20 member states that have been affected. But you remember last time we were around 124,000 cases, I think somewhere there. But this time we have almost 150,000 cases as of June 11th. What does that mean? That it's already clear that in 2025, if we don't intensify our effort to bend the curve, we'll end up with more cases than were reported in 2024. Also important to remind again that Africa this year accounts for 60% of all cases globally, and almost 94% of all deaths that have been reported. I think this is really where the intensification of effort, following on the call to action of our leaders, is critical at this moment. Next. Now, looking at the situation, in Angola, it's important to say that we are seeing now the beginning of a downward trend in Angola. During week 23, there were 956 cases compared to 1,782 That's a reduction of about 46%. That is huge. The same trend was also observed on the case fatality rate. Now, on the mortality, we had 13 deaths reported compared to 33 the week before. That's a 60% decline. That to say that all the effort of all the partners in Angola are trying to show some light at the end of the tunnel. But it's no time for complacency. I think we need to follow up on the call to action. That's the reason why the DG had to make a trip to Angola, just meet with the leadership to really provide the needed support for them to maintain the momentum and maintain the current trend. When we look at the people that are affected, males make 54% of all cases and 62% of all deaths, and children also account for 38% of cases and 32% of all deaths. But what is important that Africa CDC, WHO, and all the partners are really supporting the country with the training, the IPC, the water supplies that are being provided to Angola. But it is important to mention that 57% of all deaths are hospital-based. There's a slight decline there from we are above 60. I think last week when we reported, now we are now going below 60 to reach 57. But this is an area that also needs our attention because it might be either related to the late care seeking or to the quality of care or the combination of these two factors. I think these are some of the elements that we are still working to investigate and understand further and provide the appropriate interventions to improve the situation. But it is definitely clear that over the last 4 weeks, we have seen this sustained declining trend. Next. Also, just wanted to say a few words on chikungunya. As we said, we promised last time. Mainly in Kenya, I think Mauritius has also been affected, but no recent cases reported from Mauritius. But what we have from Kenya, that there have been 25 cases that have been reported, 0 deaths so far, case fatality rate at 0%. It is so far one province out of the 47 that is affected. That is during week 22, there were 45 suspected cases reported, of which 25 were confirmed, and all those come from 6 counties. There was also one case of co-infection, chikungunya and dengue. I think that was also identified. There to say that some of the drivers of the chikungunya in Kenya include the recent heavy rainfalls and also the stagnation of water. I think that has kind of created the breeding ground for the Aedes mosquitoes, and also the low use of mosquito protection measures in the household, and also some of the challenges on the environment related to the waste disposal and also the water management. I think those are some of the elements which could be combined also to the lack of adequate information about chikungunya, its symptoms, and its prevention measures at community level. There to remember that the last outbreak took place, that's almost 7 years ago in 2018. I think it is really the right moment to really intensify building on the lessons of the past to ensure that they do have not only the information on the measures that they need to take, but also on how they can prevent the infection in Kenya. Next. But despite that, we know that chikungunya is a virus. Right now, we have no treatment. We also have no vaccine that is rolled out yet in Africa. The management is mainly symptomatic and supportive. But the good news is that there are 2 vaccines that have already been manufactured by Valneva and also by Bavarian Nordic. The process of approval in the US is quite advanced with the US FDA and also in Europe with EMA. But here in Africa, not yet. I think these 2 vaccines have not yet been evaluated. I think this is an area that Africa CDC is working with its traditional partners, CEPI, PAS, Valneva, KEMRI, and other partners, really to test the safety and the efficacy of those vaccines in the African populations. I think it is really giving us hope that in the near future, we should be able to get some of the medical countermeasures, starting with vaccines, to be able to protect our African populations against this disease. Next. In summary, we would like to say that the move by our head of state with the endorsement of that call to action is something that we proudly welcomed, to see that level of political engagement and commitment to our continental efforts to control outbreak on the continent, and cholera in particular, given the fact that there is a target of eliminating cholera on the continent by the year 2030, which is also aligned with the global elimination target. But in the meantime, we recognize that Mpox remains of great concern. I think we see different dynamics. We have countries that we are seeing good progress. We have also countries that are still of great concern. We also have new countries that are still getting infected and reporting new cases. But it is extremely important for us to intensify our response, also targeting some of the key outbreaks, that the key challenges we have identified in these countries. For example, in the DRC, it is the testing coverage that remains a low challenge. But in Sierra Leone, we see, for example, the high positivity rate that is of great concern. I think we need a kind of differentiated response in the technical assistance that we provide to these countries as we move into our intensification, integration, and legacy phase of the response. I think, as we reported, vaccine shortages are growing, in particular in Uganda and Sierra Leone, that we really welcome any urgent support that can come from our partners. We are continuing to work with them to be able to really leverage again of the international solidarity to help those countries, as they also work very hard to control the outbreak. Now, just to say that we are getting some recommendations that are coming both on the emergency consultative group of Africa CDC. Very soon, we've also recently heard what has come out of the advisory group of WHO on the Mpox. But there's also a consensus that not only Mpox, but cholera also needs our immediate attention. I think that's the reason why in the near future we'll come back to you, because we are also trying to see how we can expand the scope of the mandate of this IMST as part of the integration that is already presented in our plan to also take on our continental efforts to stop the current outbreaks of cholera and help the continent move toward elimination. There to say that we like this momentum to be maintained, and we would like also to continue mobilizing the political support that is needed to get us to the finish line. Now, with those, Director, I would like to stop there and thank everyone for your attention and open up now for comments and questions from the participants. Over to you, Director.
Thank you, Dr. Ngashi. Let's take the first two questions that we have. We have Modalista Mhango is a journalist with Malawi Broadcasting Corporation. The question is, as Africa CDC, what initiatives are you implementing to boost the local medicine and vaccine production in African countries, considering the recent Mpox outbreaks? That's the first question. Then we have Alison Hunter. She is a New Narratives reporter. The question is there a resurgence of dog bite rabies in countries such as Liberia, the struggle from post-pandemic setbacks? And do you think the previous goal to eradicate rabies by 2023 lost support since the pandemic? Those are the first two questions. Dr. Ngashi, over to you.
Okay, thank you very much, Director. Thanks to our colleagues for those two very important questions. I think I'll take the first on the local manufacturing and the effort of Africa CDC. And I don't know if Messi, anyone from surveillance, can take the question on rabies in Liberia in particular. I think just think about that if you can get some information. Now, on the local manufacturing, just to say that, this is a priority areas of work of Africa CDC. We've also learned from the past that every time that we go through an emergency response, if you read our plan, we are talking about the legacy priorities. And Mpox manufacturing on the continent is one of the priorities that was identified right from the beginning. Now, what we've been working on is that given the fact that these vaccines were produced by Bavarian Nordic, I think that's the main supplier of the MVABN vaccine that we are doing. I think there have been already engagement at very high level of both Africa CDC and Bavarian Nordic to discuss the possibility of tech transfer to the African manufacturers to be able to build that capacity on the continent for the future production of Mpox vaccines. Just to reassure that this is really work that is ongoing. And right now, as we are talking about, we are also facing the cholera vaccine challenges. And again, as you know, that last year and this year, in 2024, 2023, Africa could not mobilize the quantities it needed for cholera vaccines as well. In that area as well, we are working on the tech transfer. At least progress is much more advanced on cholera than it is on Mpox. We have the tech transfer that has already been approved to local manufacturers. I'm not going to mention the names right now, but already that is quite advanced. We have the tech transfer to at least 2 manufacturers on the continent that do have capacity to start producing as soon as 26 for the first one, and the year 27 and 28 for the next one, to produce now those vaccines locally on the continent. That to say that we keep our accelerator on the local manufacturing agenda as part of the independence of Africa that we always talk about. Now, on the dog bites, yeah, I think I'll invite Messi to make a comment on the dog bites.
Thank you so much, Dr. Ngashi, for that question and for giving me the floor, and thanks for the question on the rabies. As you're aware, rabies is a zoonotic, one of those zoonotic infections that as Africa CDC, we've also been following up, and our surveillance system has been tracking this around the continent. We received an alert of over 78 reported dog bites from Liberia. And we also understand that definitely to be able to put together a robust strategy or mechanism to be able to control this, we need a very, very strong One Health mechanism or multi-sectorial coordination mechanism in the country. And Africa CDC has been working with Liberia to strengthen that arm, also knowing fully well that Liberia also had established a national rabies strategy from 2023 to 2027, outlining clearly what approach they want to take, what steps they want to take to be able to control and eradicate rabies. But again, as Africa CDC, one of the things that we're doing is engaging the country to understand more detail what the exposures look like, if they have stockpiles in terms of the post-exposure prophylaxis and other and other medications or countermeasures that can be able to support some of the management. So our One Health team is fully aware of this situation, and they are engaging the counterparts in Liberia. Hopefully by next week, we'll be coming back with you on what has been done. But just also I highlight that last 2 years, we're also following the same with as other countries like Zambia, who also reported the same. And one of the strategies that we're able to do is to use their early warning system which we've also supported them to establish that's the event-based surveillance system to be able to track information across different sectors and able now to help them for preparedness. So these are some of the strategies and systems that we can use to be able to ahead of time put our stocks, our stockpile, and also ensure that we have enough risk, our community engagement for owners of dogs to also get them vaccinated and all that. So it's more or less a multi-sectorial collaboration as well as requiring different sectors for intervention. Over.
Thank you. Let's cross over to the floor. We have Zinile is a reporter Bloomberg. Over to you, Zinile. You have the floor. Zinile, if you can hear us.
Hi. I had a question about the new strain of COVID-19. This is a new strain, and whilst I'm aware that it's from the lineage of Omicron and probably won't be a big problem for South Africa. But I was wondering, how is the CDC monitoring it, especially in the places in the vulnerable regions, like your Sierra Leone and the others?
Thank you, Zinile. Let's take the next one from Allegra. You have the floor. Allegra, can you hear us? Allegra, can you hear us? All right, let's take the next one from the chat box. We have a question from Iris. The question is Africa CDC has done well with regular updates on health emergencies in the region. However, emphasis has been on disease outbreaks. Could we also have a feel of the situation around conflict-induced health emergencies as well? Dr. Ngashi, you can take those two. Over to you.
Okay. Yeah, thank you very much, Director. I think the first question is on surveillance. Macy will take that. We know that this new variant of COVID-19, which is called the Nimbus, the NB181, is a threat to many of us. I think it has affected over 20 countries. But the good news is that we went through COVID-19 already. We have some experiences. I think all the effort now is to reactivate, I think, the surveillance system to be able to track the NB181. I think Macy will come back to that. Now, on the Iris question about conflict-induced health emergencies, I think it is quite interesting. I don't know if there is a combination of factors. We have health emergencies that preceded conflict, like in the Eastern DRC, and then we had already cholera, we had already Mpox, and then emergencies, conflict coming. It is the same situation that we see in South Sudan. But then at the same time, as you also go into an emergency, what we see is the worsening of those emergencies that were there before, with the risk of the resurgence of new ones. For example, you can get measles, you can get even cholera, where cholera hasn't come in. The response in those settings has always been an integrated response that aimed at addressing the emergencies that already exist. As we went through DRC, is to address both the Mpox and the cholera, but at the same time also to prevent the new one. For example, with the vaccination of children against measles, to ensure that not only that you are trying to control what is already there, now being worsened by the situation of emergency with the displacement of population, the difficulties to even bring in the supply, the difficulties to maintain the healthcare workers and so on. But at the same time, also prevent those those might arise. Just to say that one of the challenges that we've had, if you remember even last time when the DG made the call, is that when these emergencies happen, it is always important to secure a humanitarian corridor to be able to provide that integrated package. I think that has been the challenge in the past, and that then also forced us to mobilize new partners to be able to continue with the emergency response. That's when we also engage with the organization that work in those contexts, like the OCHA, the HCR, IOM. I think those that work with migrant and population and mobile populations, to be able to integrate also some element, of intervention in the package of services that they provide in those contexts. Just also to say that it's also in that context that we also integrated even the use of community health workers. As an important, because community health workers are people that move with the population, that they move so that we can then ensure the continuity of basic services as well. Because it's not only the emergencies that are there, the emergencies that arise, there's also the continuation of basic services that also worsen during emergency, that there's complete disruption of services because the clinics might be destroyed or population can go to areas where there's completely no facility. I think those are the three kind of strategies that we have used in the past, and we have also learned that emergency situations are much more complex and require much more players and require greater engagement of resources that you also have at community level. I think those are the things. If you heard even during the call to action on cholera, there was a specific call for that context of emergencies that will also push our head of state to commit also to facilitate those humanitarian corridors, for the delivery of that integrated package in the context of the emergency. Because an organization alone cannot do it. You also need the state itself. You need the partners that have a footprint in those contexts to be part of the response as well. Now, on the COVID-19.
Okay. Thank you so much, Dr. Ngashi. As colleagues, as you are aware, most of our countries on the continent, after the end of the declaration of COVID-19 as constituting a public health emergency of global concern or international concern, most of them shifted from active surveillance to more or less certain sentinel surveillance sites in countries. So they've actually been monitoring, but more or less in specific populations. And as Dr. Ngashi rightly mentioned, the NB 181 is a mutated Omicron. It's highly transmissible, but again, the information on its severity, it's not provided yet. It's limited, let me say so. And on the continent, we have certain markers that will really point us to if we're seeing high severity or high proportion of death across the different countries. And one of those is the hospitalization rate, or let me say the bed occupancy rate for those diseases. But again, for the countries that have set up sentinel surveillance for serially, they are actually doing some monitoring. Recently, Rwanda also came up with a statement to say they're seeing a surge in COVID-19 cases. And so our team actually following up to understand if this is the variant that is currently under monitoring in Uganda, in Rwanda, to be more, sorry. And it might also interest you to know that WHO in May has marked this variant as a variant under monitoring. That just shows that it's something that really not yet under of concern yet, but needs to be monitored so that more information, especially around the severity it's gotten, and then more actions can be taken to that regard. But as of now, it's highly transmissible. We're seeing many more countries being affected. In America, it's spread over to several states. On the continent, we're yet to get very granular information on the distribution, but definitely it is something that we can come back during the next brief to provide you more updates on the same.
Thank you, Dr. Mason.
Yes, Director.
Let's take the next two. Thank you. Let's take the next two questions. We have Jonathan Lambert from NPR. The question is, what's the capacity of hospitals in Sierra Leone for treating Mpox patients? That's the first question. And then we have another question here from Catley of The Guardian, UK. The question is, last week you said Sierra Leone had struggled with contact tracing and vaccination due to no available funding for community health workers. Has there been any progress on that front so far?
She's frozen. She's frozen. She's frozen. Director, can you hear me?
We can hear you.
Okay. I think she asked for two questions. The first question is on the bed capacity in Sierra Leone to take care of Mpox patients. We can say that, at the beginning, there was a considerable challenge. I think Sierra Leone only had 60 bed capacity. We discussed with the minister yesterday and got an update that they have gotten 600 beds, not in hospitals now. They're building structures that are just for the isolation of Mpox cases. They had one structure of 400 beds. They have also built two additional structures of 100 beds each. That brings the capacity now, if you add those 600 beds additional of the 60 that were there before, that's about 660 if they haven't continued after that to build more. Just to say that the situation is far, far much better than it was before. And then on the challenge they had with community health workers, right now, I think the problem is that they started this good initiative, which was the Find Them All, it was a good initiative, but it had two main challenges. One is the focus on cases, not on community-based surveillance, with the other important components like the identification and contact tracing, the promotion of infection prevention and control, given the fact that some of the patients will still continue to be taken care of at home, and also the overall risk communication and community engagement. I think they had that focus on case identification. Now, what we have done, we Africa CDC and the IMST, we are going in there, we provide funding to work with the government to be able to reactivate the Find Them All, but now not as the Find Them All only, but the community response to Mpox that include the other elements that I've just mentioned, to say that you find them, you also identify the contacts of them, and then also monitor those contacts and also work with household on infection prevention and control, and pass on the right information on the disease and how to protect against it, and how the communities can go get engaged and play a role in the control of this outbreak. Africa CDC is doing that right now. There is a mission that is going there next week, exactly to bring that support on the community health worker in particular. But it's not going to be limited to that. We're also going to support the IPC supplies. which is an area that the ministry is also wanting support, as well as the vaccination. As you know, that Sierra Leone is also looking for additional vaccines that will also need to help them look at the vaccination strategy itself, how they can then identify more people to vaccinate, in addition to getting additional doses into the country. I think those are the different areas of support that Sierra Leone is going to receive from Africa CDC and the partners here in the continental IMST.
Thank you, Dr. Ngashi. Let's cross over back to the floor. We have Paul from the Lancet. Paul, you have the floor.
Yes, thank you very much. So, Dr. Ngashi, you recently reviewed that IMST's responsibility will soon be expanding or has already expanded from Mpox to cholera too. I'd like to know if the initiative's capacity is robust enough, and whether the request from the African government came with additional funding for IMST, or is the available funding and system or whatever IMST have been expanded or stretched to include its new cholera responsibility?
Thank you, Paul.
Thank you.
Sorry, Dr. Ngashi. Let's take the next one before you come in. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Hello there. Thank you for giving me the floor. I wanted to ask Dr. Ngashi, does the Africa CDC have a way of, I know you work with government in collaborations. The relationship is not supposed to be antagonistic, but do you have a way of verifying some of these information they give you, because you need this to make, proper decisions as to how you help them? So I ask this because I know I've been following this, as you may remember, what we do here. Yesterday, I asked this particular question you mentioned about bed capacity. Somebody asked. I asked the head of the National Public Health Agency, and the number he gave me about available beds were 594 exactly. Now you are mentioning, speaking to the minister, and you mentioned about 600 and something. And in relation to that, about the Find Them All, the Operation Find Them All, in previous press conferences, including the last one, you mentioned that it was stopped. And again, this was something that I took up with the official yesterday. He said it had never stopped. And as far as he was concerned, it was going on. How do you get your information, and what can you say about these seeming discrepancies? Thank you.
Over to you, Dr. Ngashi.
Excellent questions. I think let me start with Paul. To say, Paul, your question is extremely important. You see, we are operating in the context of reduced resources. I think that is the motivation, because now all the partners are demanding of us results, efficiency, sustainability. It is those three things that are coming, from our partners. Now, that focus on result, efficiency, and sustainability, it is in the context of really reduced new resources, in a way trying to push us to optimally use what we have already. We were able internally at Africa CDC to mobilize additional funding for the IMST. But because we don't know yet what is going on, as you know, WHO is going through a number of reforms, I think, that were announced at the World Health Assembly by Dr. Tedros. And we don't know yet how that is going to play with WHO contribution to the IMST in particular. I think it's also something that we are following up very closely to see how that would happen. But on the Africa CDC side, we've also tried then to reorganize internally to be able to allocate resources, additional resources to the IMST, but recognizing that as we do that, we won't get the capacity to multiply different structures to manage all these outbreaks that are coming on, given the fact that we are also facing the same constraint. That's the reason why on one side we've added additional resources to it. At the same time, we're also pushing for the integration so that we can really bring as many as possible to optimize the use of the resources that are already being available through the IMST for Mpox to also address cholera and any other outbreak that can emerge. I think that's where we are, but we also know that there's still a lot to discover from our partners as well. As you know, even UNICEF has also contributed a lot. All of them are going through internal adjustment, with what has happened. I think we are still yet to know more from our partners as well. But I can confidently talk about Africa CDC because we are part of the management. But with the others, we are following up very closely to see what are the implications of that. On the question about Sierra Leone, I think the question from Kemo Cham, I think just to say that one good thing is that I see how the information that we just received from Liberia yesterday correlate with what you are just saying. You said that you asked somebody that spoke about 594 beds, and here we heard yesterday about 600 beds, which means that 594 and 600 almost the same thing. The only difference is that I just added the 60 beds that were there before at the beginning of the response to make them 660. That is one thing. Now, your question is, how do you verify this information? I announced that there will be a team. I'll be leading a team myself to Sierra Leone. We'll be visiting the country next week if all the preparation goes well. It's also an opportunity to see on the ground what the reality is. But to be honest, we are the African Union. We have no reason to doubt what the member states are telling us, because there's no good relation if there's no trust. But once on the ground, we see what is the situation and where the limitations. We are always there to support our member state to expand the capacity that we want them to expand. Now, your second question is you are talking about the find them all that stopped, not stopped. We'll also get to touch on that exactly, the reality on the ground. But I'll just tell you something. If remember the data that we presented last week and today, you'll notice that the positivity rate of Liberia is around, of Sierra Leone, I mean. The positivity rate of Sierra Leone is about 85%. And last week, we presented it that seven districts were reporting 100% positivity rate. 100% positivity rate, what does that mean? Is that every person that comes with the symptoms that meet the case definition of the disease is testing positive. And that in a case of an emergency, that happens when people come at advanced stage of the disease, after they have already taken a long time to come, and in most cases, it is the passive surveillance. Now, if they find them all as working, we cannot get the positivity rate at 100% in at least 7 districts. I think that's the way we also try to make sense out of the data that we are receiving. If it's there, then it's not performing. I think it's either it is there, or it's whether it's not working at all, or it is working but it's not performing. Because if all the cases come from the health facility, then you ask yourself, where is then the community-based active surveillance? We should be identifying these people much early, and usually the normal positivity rate when you have active case finding is between 30 to 40%, meaning that you still have people that also have other skin-related diseases that are not necessarily Mpox that are also picked, but then the diagnosis makes a difference. I think that's what I can say, but as a way of confirmation, is through the country missions that we have an opportunity now to go and see exactly the reality on the ground. I think that's what I could say at this stage. Over to you, Director.
Thank you, Dr. Ngashi. We apologize for going over the time. We have 2 more questions before we adjourn. We have Esther Nakazi, a science journalist from Uganda. Esther, you have the floor.
Thank you very much, Dr. Ngashi, and thank you, Margaret. Dr. Ngashi, we have heard that most of the vaccines that come into our countries are basically stockpiles from other countries, and these have a very short shelf life that we have to play into to distribute to the people. But I'm also wondering, are there vaccines that are being manufactured as of now from the developed countries that you're sending to us, or we are just getting those old vaccines that were stockpiled somewhere and they have a very short shelf life? Thank you so much.
Thank you, Esther. Let's take the last one. We have Lisa Shearing, the news editor from CIDRAP News. The question is, there was a report from virologists a few days about the possibility that a new clade 2B variant called G1 is responsible for some of the exponential spread in Sierra Leone. What's Africa's CDC's view of that? Over to you, Dr. Ngashi.
Yeah, thank you very much. I think on the first question from Esther about the vaccines, they have to say that the vaccines come from a combination, yes, of stockpile, but also of the manufacturing. Remember that Gavi vaccines were procured, and even the UNICEF vaccine were also for procurement. That means production and then buying from the manufacturer. At the same time, we also got stockpiles from countries like the US, Canada, France, Germany, Spain, a number of countries that, as part of the international solidarity, shared their stockpiles. Not all vaccines were of a short shelf life. I think we have vaccines that go to 1 to 2 years. We have vaccines that were below 1 year. But it is in the distribution that we have taken that into account to see that where we have vaccines that have a shorter shelf life, then we look at a country that has got a high absorptive capacity that can then absorb those vaccines much faster before they get closer to the expiry date. I think that's not the way that we have addressed the vaccines. It's a combination of both. But in the long run, is that as we discussed before, we are pushing for the local manufacturing in Africa. That's our vision, so that then we can ourselves control those stocks. We'll be able to control everything, both the quantities and the shelf life and everything. I think that is the vision there to reassure that we are looking at all this. Now, the second question is on the, it is the result of the sequencing in Nigeria, which then showed that link between the virus in Nigeria, that 2B, and the mutation in Sierra Leone, that then concluded that most likely this virus, the mutation in Sierra Leone, might have originated from Nigeria. And remember that this is the work of Africa CDC. During the COVID outbreak, there were only 2 member states that have sequencing capacity. The very reason why Africa CDC distributed these sequencing machines is to be able to establish exactly this kind of information, which is also critical for the control of the outbreak. It's something that we supported, we continue to support, really building the capacity of all 55 member states to have the sequencing capacity to be able to establish this kind of evidence, which is critical in every outbreak response. Over to you, Derek.
Thank you, Dr. Ngashi. And with that, we have come to the end of our weekly briefing this week. I'll hand over the floor back to you for your closing remarks. Over to you.
Thank you very much. I think let me first just start by thanking all of you for your continued attention and interest really in the work that we are doing. We've been in this for more than 6 months, and we can see this sustained interest is something that don't go unnoticed. It really goes straight into the heart of Africa CDC and the entire continent of IMST. They are to say that we are at a very interesting time in history, But your questions, the question that you asked, they also point us in certain directions, on things that are important that we should be taking care of. Even some of the questions, some of the outbreaks and so on, all those, I think you might not realize it yourself that through those questions, you are also making a great contribution to the work of Africa CDC and the work of the Continental IMSC. We like to really thank you sincerely and look forward to seeing you next week, same day, at the same time.